let us complete our study of hematologic malignancies, lymphoma, and then the platelet disorders as a separate issue. Lymphoma. If you took CLL and put chronic lymphocytic leukemia in a centrifuge and removed all the liquid, all the plasma and the red cells, and you made a ball of CLL cells and put it on the neck, that would be lymphoma. If you took a lymphoma, a lymph cancer, put it in a blender, juiced it up, and made a lymphoma smoothie and injected it into you, that would be CLL. Lymphoma is a solid lymphocytic malignancy. CLL is a liquidy, blood-borne lymphocytic malignancy. Both cells look normal. Very different from a blast. Acute lymphocytic and acute myelogenous leukemia. These cells have blasts, and these cells on smear look very evil. Whereas CLL cells, the smear looks normal. There's not that much evil looking in that smear. The smear looks normal. So if the smear looks normal, you're not going to have much there to see to tell you it's CLL. The same with lymphoma. The individual lymphocytes look pretty good. The individual lymphocytes look okay. They're not that abnormal appearing. That is why when you have people, when you think you have lymphoma, 32-year-old woman with a neck mass. The neck mass is not warm, not red, not tender, because warmth, red, and tenderness imply infection. The biopsy to do is an excisional biopsy. The first answer for people with lymphoma is biopsy, yes. That you won't have a problem knowing. But the first problem is what type of biopsy? Needles are good for infections. I have Staph aureus, fungus, tuberculosis. Bunka, 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 bunka. Put a needle in it, smear it. Hey, it looks like a fungus. Hey, it looks like tuberculosis. But the biopsy in a neck mass and lymphoma doesn't look so bad if it's a needle because the smear is normal. You need an excisional biopsy. Take the whole thing so you can see the architecture of how these things look together. An excisional biopsy, looking at the entire lymph node structure, is how you're going to make the differentiation. Now, lymph nodes can be reactive tissue. Most reactive tissue is going to be tender, warm, red. Lymph nodes that are with lymphoma are going to be just firm, rubbery, and non-tender. Once you know that the person has lymphoma, the first thing to do is to decide the question, can I safely radiate this patient? If the person has stage 1 or 2 disease, you can treat stage 1 and 2 disease predominantly with radiation. If you have advanced stage disease, stage 3 and 4 disease, you will treat predominantly with combination chemotherapy. Now that chemotherapy for Hodgkin's disease is ABVD, Adria, bleomycin, vincristine, dexamethasone, or with CHOP, with a person who has non-Hodgkin's lymphoma, where it'll be CHOP, where it's a different set of therapies. However, whether it is ABVD with Adria, bleomycin, vincristine, and dacarbazine, or whether it's CHOP for the non-Hodgkin's lymphoma, the key issue is, can I safely radiate versus the chemo? The boards are much more interested in the fact that you know to do an excisional biopsy and the fundamental question of radiation versus chemo than in particularly which chemo. Little fourth-year medical students are not going to be sitting around making major therapeutic decisions of which flavor of chemotherapy. The advertisement of knowing which is the adverse effects is much more important. What are the adverse effects? Listen, I didn't choose the chemo, but that other smart guy, the consultant, gave the chemo. Now I sit around later on and I figure out whether this peripheral neuropathy is from vincristine, whether this peripheral neuropathy is from vinblastine. What do they have this pulmonary fibrosis from? Because I deal with the adverse effects of the chemotherapy that he chooses. So the general doctor's got to manage the side effects, whereas the oncologist is going to do the individual choice of drugs. So for step 2 students, knowing the adverse effects of medications, knowing that vincristine causes peripheral neuropathy, vinblastine, vinblastine cause peripheral neuropathy, knowing that bleomycin causes pulmonary fibrosis and busulfan cause pulmonary fibrosis, busulfan, vincristine, vinblastine, pulmonary fibrosis, peripheral neuropathy, is more important than what particular choice of chemotherapeutic agents per leukemia. That's not a very step 2 knowledge base, but adverse effects is. I get an excisional biopsy, and then the question is, what stage are they at so I can know how to treat them? You chemotherapy anybody who has stage 3 and 4 disease and anybody with B symptoms. Any stage with the quote-unquote B symptoms. And the B symptoms are evidence of the microscopic spread of the cancer around the body. Fever, weight loss, night sweats, fever, weight loss, night sweats, fever, weight loss, night sweats. The signs of the microscopic spread. Any stage that has B symptoms is going to be treated predominantly with chemotherapy because you can't radiate the neck and expect to eradicate microscopic spread elsewhere in the body. You can't radiate my pelvis and eradicate microscopic spread around the body. I would be glad for you just to radiate my neck, but if I have disease in my pelvis, I'm going to die. So the question is this: can I safely radiate? And the ones that are treated with radiation is basically stage 1A and 2A disease. One lymph node group, stage 1. 2 lymph node groups, stage 2. Stage 3 is both sides of the diaphragm, above and below, both sides of the diaphragm. Once I know that I have disease on both sides of the diaphragm, I cannot safely radiate a person who has disease on both sides of their diaphragm. People who have disease on both sides of their diaphragm have to be treated with chemotherapy. You can't radiate my whole body. What are you going to do, put my whole body in a microwave oven? The radiation would kill me. The chemotherapy is less toxic to the whole body than total body radiation. Radiation has to be focal. Now, you may be waiting for me to tell you, once you do the biopsy, then say chest CT. Once you do the biopsy, then say abdominal CT. But rather than me saying, first do the chest CT, then do the abdominal CT, then do the pelvic CT, it is much better for me to say the question, can I safely radiate? Because that question will never change. What might change is your question might tell you, they've had a chest CT. What would you do next? Well, I'd do an abdominal CT. Well, your question might say, well, they've had a chest and an abdominal and a pelvic CT. What would you do now? Oh, the chest, abdomen, and pelvic CT are all negative. What would you do now? Well, I still can't safely radiate until I make sure that my head and my marrow, bone marrow, are clean. If I radiate my neck and it turns out that I've got lymphoma in my marrow, I'm going to die. So therefore, the question is, can I safely radiate a local lesion? Therefore, your question might say, a guy comes with this neck mass and they've got pancytopenia. The marrow shows lymphoma. Next step, chemo. Why? Because there's no point in doing staging for a person you know already needs chemotherapy. With the Hodgkin's disease and AIDS ABVD, adriamycin, cardiotoxicity. Adriamycin, cardiotoxicity. What reverses it, that cardiotoxicity? What reverses the cardiac toxicity of adriamycin? Nothing. Ooh, that's not so good. Bleomycin, pulmonary fibrosis. Here's Chemo Man. Hello, Chemo Man. Chemo Man. Pulmonary fibrosis. What reverses the pulmonary fibrosis of bleomycin? The answer is nothing. If you fry someone's lungs with bleomycin, they're not coming back. They're like fibrosed organs that either get better or they get worse, but you cannot do anything to reverse it. Therefore, before I give them bleomycin, I better be certain that the person really needs this drug. Meaning, if I have a localized neck mass, personally, for stage 1A disease, that radiation has greater than 95% sustained remission for one localized disease with Hodgkin's disease. Ooh, very good. What's the other good news? Hodgkin's disease presents in stage 1 or 2 disease 80 to 90% of the time. Wow! Hey, everybody used to die with Hodgkin's. Now, it's 90% curable. Even stage 2 disease, you get 85 or 90%. Now, personally, I'd be visualizing the 5 or 10% failure rate because that's the nature of doctors, to visualize the failure rate. That's why the doctor meetings are never held in Las Vegas, because they know the odds go against them at the end. However, if I got to have something, stage 1A Hodgkin's, 95% curable. Radiation, well, it's not a walk in the park, but if you're just radiating a neck, worst thing, might get dry mouth from zapping the salivary glands, could get thyroid cancer. However, it's still small, and it's a lot better to be alive with a dry mouth than dead with a lot of saliva. So therefore, Hodgkin's disease, why do we want to radiate? Because it's got a good cure, and they don't have the long-term adverse effects of these chemotherapeutic agents. Now, Hodgkin's disease gets radiated a lot. Non-Hodgkin's lymphoma is more of a problem. Non-Hodgkin's lymphoma is presenting in stage 3 or 4 disease 80 to 90% of the time. Oh, that means we're gonna chemo these people most of the time. That is a problem. What's the most common adverse effect of the chemotherapy? The answer is infertility. 90% of people who get chopped, I told you, oncologists have very uncheerful acronyms, and this is their most benign, CHOP, compared to all the other things. Cyclophosphamide causes hemorrhagic cystitis. See the cycles? Look, hemorrhagic cystitis, cycle, cyclophosphamide, cycle, 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 hemorrhagic cystitis with the cyclophosphamide. H is hydroxyadriamycin. Now, one would wonder why they didn't call it COAP, which would come out to being COAP cope. Why, we're going to make you cope with this disease. No. Hydroxyadriamycin, to make it a chop. Hydroxyadriamycin. Cardiac toxicity, nothing reverses it. What about oncovin or vincristine? Vincristine causes peripheral neuropathy. Vinblastin, here, vinblastin causes peripheral neuropathy. Chemo man, taking a beating for you. Bleo, busulfan, cyclophosphamide, vincristine, vinblastin. Those peripheral neuropathies, there is no treatment to get it better. Adriamycin and cardiotoxicity, no medication will make it get better. Busulfan and hemorrhagic cystitis, you can prevent it, but you can't make it get better. So I would like to get radiated, but before I get radiated, you better make sure I'm local. Oh, I biopsied you with an excisional biopsy. Can I safely radiate you? Well, you better make sure I don't have disease here, here, and here before you radiate me. Because if you radiate me here and I have disease under the diaphragm, I'm going to die. So you better make sure it's local. The point about lymphomas. Ready? Excisional biopsy. See if it's local. If it's local, radiate the local disease. If it's widespread, stage 3 or 4, or anybody with B symptoms are fever, weight loss, and night sweats, this implies microscopic spread around the rest of the body. You can't radiate the local. You have to do systemic chemotherapy. Oh, when I was in medical school, I used to look at this and it used to say, well, get liver function tests and get a CBC and get a serum protein electrophoresis and get a urinalysis and get a urinary electrophoresis. And I used to go, oh my God, how am I going to figure this out? That's like everything. Get me everything. It's like the Dalai Lama and the hot dog man. Make me one with everything. Excisional biopsy first, and the question stays the same. What will change the therapy? These won't. The liver function tests was to give you a clue. Is it inside my liver? The CBC was to give you a clue. Is it inside my marrow? Same with the electrophoresis. Can I safely radiate? And then, why don't I chemo everybody? I used to look at this and go, it's too complex. I think I'll just chemo everybody and I don't miss anything. Get done, skip the testing. Let's chemo everybody. The reason why not is because chemotherapy, 1% per year go on to leukemia. And as we said, 1% is only a small risk if it's not your risk. 1% a year, that means by the time this person is 50, they got a 20% chance of getting leukemia and dying. Because if you have leukemia as a result of chemotherapy, you can't very well give chemotherapy to eradicate it because it means that those leukemic cells grew around the chemo. That means that they're resistant. Leukemia, aplastic anemia, not to mention the peripheral neuropathy, the cyclophosphamide-induced hemorrhagic cystitis, the bleomycin pulmonary fibrosis, the cardiotoxicity. Now, although it's not in this person, in order to make it complete here, let's finish the other drug toxicity. What's the toxicity of cisplatin? Renal toxicity for cisplatin. Renal toxicity, the kidneys. Renal toxicity, cisplatin, and auto. Renal and auto, chemo man. Cisplatin, renal and auto, cisplatin. Bleo, busulfan, vincristine, vinblastin, cyclophosphamide. Radiate the local, chemo the widespread. Why don't we chemo everybody? Because of adverse effects. The other addition to non-Hodgkin's lymphoma is a medication called rituximab. And rituximab is monoclonal antibodies against their CD20 antibodies. It turns out that non-Hodgkin's lymphoma expresses CD20. CD means cluster of differentiation. It's like a zip code for the lymphocytes. How do I know which lymphocyte does which one? How do I know if I send you a letter at 101 Main Street, it ends up in 101 Main Street in Flushing, Queens, or 101 Main Street in Texas? If I send you a letter to Albany, And Main Street in Albany, how do we know it goes to Albany, Georgia, or Albany, New York? Zip code. Antibodies against CD20, which are expressed in increased amount in people who have non-Hodgkin's lymphoma, anti-CD20 antibodies. They have limited side effects, and it has an effect on eradicating the lymphoma cells. Precision targeted weapons that attack only the lymphoma cells and not the normal tissue, because normal lymphocytes don't express CD20. In the future, we will have much more directed therapy. So we can make antibodies that target the cancer cells, but the problem is the punch, the attack, the bomb attached to it is not enough to kill the cells. But this one at least will pull some of those cells out and is used with CHOP, the P is prednisone, with CHOP in non-Hodgkin's lymphoma. Almost everybody non-Hodgkin's gets chemoed because almost nobody presents with localized disease. The staging is the same for both Hodgkin's and non-Hodgkin's. The staging is the same for both the Hodgkin's and the non-Hodgkin's for both patients.